for Andrea Warner-Steidham, the advanced nurse practitioner from Kent State University, who's part of our team, to be here to present on dialectical behavior therapy, or DBT. But Andrea's had some family issues going on, some health stuff within the last year, and thankfully was able to give us a bit of notice that we needed to come up with something else. And well, on one hand, I thought, yeah, we could plug in something we've done before, because that would be easier. On the other, it's probably good for me as a counselor to kind of dive back into some of my clinical skills a little bit that I haven't been necessarily using as much. So it's kind of fun to do a little bit of a research, to relook at DBT when I haven't done that in a while. So if you guys are familiar with DBT, dialectical behavior therapy was developed by Marcia Linehan, or Linehan?
I've heard Linehan, but
Linehan?
I could be wrong.
We'll go with Linehan.
I haven't heard her say it.
So she developed this when she was working with a group of women with borderline personality disorder who had a high risk for suicide, a lot of suicidal and parasuicidal behavior, non-suicidal self-injurious behavior, and were demonstrating a large amount of difficulty with emotion regulation. Since she developed it, it's actually been studied with a number of disorders, but the evidence is definitely the best for borderline personality. But they have looked at it and found promising findings for patients who meet criteria for binge eating disorders, substance use disorders, depressed elderly patients. And what it is a combination of, it's a comprehensive approach that combines a bunch of different types of therapies to really target those behaviors that put people at risk for high risk for suicide and the non-suicidal self-injurious behaviors, emotion regulation. Part of the thinking behind DBT is that chronically suicidal patients and people who engage in self-injury often have a history of trauma, often a very complex and long history of trauma. They've very often been raised in profoundly invalidating environments and very often have a ton of internalized stigma. So these are people who really started to identify with a sense of self-shame, lots of negative self-talk, and they truly need a climate of loving kindness to be able to thrive. Many people with borderline personality disorder, and I feel like this is hopefully starting to change a little bit, but when I started practicing as a counselor, part of what I was trained in how to pick up if somebody had a borderline personality diagnosis was, does the hair on the back of your neck stand up? And in truth, they're very difficult individuals to work with. But when you do find the ability to get them, when you get them connected in therapy and they see you as an ally and not an adversary, and they feel genuinely validated as a human being, and like you're willing to be there with them and accept and validate them for who they are right now, then you actually can start to work with them on pointing out how some of their behaviors are maladaptive. But you have to get past that point of, it's not you that's bad or maladaptive, it's not you that's wrong, it's your behaviors. And if you want to be successful, you actually have all of the control in the world and the power to change your life, but we have to figure out how to start making, choosing some different behavioral alternatives. So a standard DBT package would be weekly individual counseling sessions of about an hour. And when I was looking through stuff, I didn't necessarily find how long this should go on for. I know that some of the programs in the Akron area, I think, what are they, like 6 weeks, 8 weeks, maybe 9. So the places that go for the traditional packages of them attached to hospital systems, I do believe have a set number of weeks. But you could engage in individual counseling sessions and the individual DBT portion for an extended period of time. It's sometimes for people who have complex trauma, maybe up to several years. At some point, I would hope that it wouldn't need to be weekly, but certainly having a regular, multi-year connection with a therapist is not uncommon for people with this kind of disorder. The standard package also includes weekly group skills training sessions. So this is an 1.5 to 2.5 hours, and this is part of that kind of package that would be for 8 or 9 weeks. And I'm making a guess because I can't remember how long the weeks were the last time I referred somebody there. I've never done the group skills training portion. I've just engaged in individual portions. There's also in a standard DBT package, weekly consultation amongst all of the therapists providing care. So ideally, if a person was working in individual therapy and group therapy, in working on DBT, then those individual therapists and group therapists would be meeting once a week by phone or Zoom or something to make sure that they were touching base about the people in the group and the individual patients and all on the same page and aware of the same things. Because as we know with any team of providers, patients often tell me one thing and Doug another or vice versa. We just get different flavors of people because we're because of humans. It also involves phone coaching as needed. So if you are a DBT therapist, you need to make yourself available by the phone in between counseling sessions, which in many agencies that's difficult unless they've figured out how to bill for some of that. And when I was working in a community mental health agency, the way that we got around that is any of the phone stuff we billed as case management. And then you just have to make sure that you somehow keep that person on the phone for 8 minutes if they have Medicaid. It's an interesting little trick of the trade, I suppose. The standard DBT package, the actual therapeutic modality, is a combination of cognitive behavioral interventions, things like behavioral assessment, contingency management, exposure therapies, cognitive restructuring, and skills training. And there are 4 basic components or modules that are very specific to DBT that you'll find in any version of DBT. In addition to the cognitive behavioral interventions are kind of more as what's needed based on the person. So these 4 core components or modules are mindfulness, and mindfulness you'll find is the core of all of DBT. It really is underlying all of the other pieces of it and helps set the person up for being able to progress through the other pieces of it. So mindfulness, really helping the individual to accept and tolerate powerful emotions and accept and tolerate themselves in the world as it is right now. There are a lot of different schools of thought around mindfulness, but I think mindfulness can be boiled down in a very simple way in just trying to be here right now without assigning any kind of judgment to it. There are a lot of different kinds of techniques and skills that you can use to help develop and enhance mindfulness and to help people, particularly when they're going through some pretty intense emotions. The more you practice those when you're not having an intense emotion, the easier it becomes to stop and practice those when that intense emotion develops. The other piece of it is distress tolerance. Distress tolerance really focusing on that ability to accept in a non-evaluative way, in a non-judgmental fashion, both oneself and the current environment, which is hard. I mean, that's an incredibly challenging thing to do, but something that we really need all adults to be able to do, and something that we hopefully are teaching our kids early on. Actually, the PACS Good Behavior game is really good at teaching all of these things. It's probably why it's so effective with helping people be more functional adults later, because if you teach kindergartners how to do this stuff, then chances are you're going to have healthier adults.
Yeah, good prevention.
Oh yeah, absolutely, good prevention. So some of the distress tolerance skills are like self-soothing, teaching people to weigh pros and cons. Radical acceptance is one of the ones that they talk about a lot, and that being something very similar to mindfulness, in that you don't necessarily have to like a thing, but we still need to accept it where it's at. And if you can accept it, then we can start to pull some of the judgment away from it. Turning the mind, so just intentionally trying to think in an opposite way, improving the moment, and there's some pretty specific strategies that you can use it, and they use acronyms, so distract and improve the moment are 2 of them. And I didn't include those because I feel like then we're just getting into a lot of meat, and it's probably more than what we need for an echo session. The third part of it being emotion regulation. So it's teaching a set of skills to help individuals alter their conditioned response to the stimuli. So we have a conditioned response. By the time we're adults, we all have various conditioned responses, and we have to actually be able to learn how to change that. For many people, that means they actually have to learn how to understand and name their emotions. Understanding where emotions come from, why those emotions are spurring maybe what they have to do with past things, if any past things. We also teach them to change unwanted emotions. So, focusing on try to use an opposite reaction to what your gut reaction is. Fact check whether or not this is realistic. Using problem solving. We also want to reduce the vulnerability to high emotion states. So the more people can practice and develop some mastery in identifying and labeling and kind of corralling the emotion, the more they're going to feel a sense of accomplishment and mastery with it, and more they're able to protect themselves from future vulnerability when sometimes something big happens that would then lead to an associated set of emotions. We also want to teach to manage extreme conditions, so helping them prepare for a crisis situation so that they're able to remain calm and stable within that crisis. And all of this, is using distress tolerance skills and mindfulness. That's why all of these things really do connect to one another, and trying to let go. So just that the concept of, yes, this is how I feel, but I'm going to let it go and not remain attached to it. So there's kind of a piece of this that feels a little bit like some of the Buddhist mindfulness meditation techniques, which is one of the things I find kind of cool about it. But you're also doing it in incremental fashions and figuring out what are the particular techniques that are going to work for that person. The fourth piece of it is interpersonal effectiveness. So strategies that help a person ask for what it is they need, be able to resolve interpersonal conflicts. And we're going to dive into a couple of these a little bit more. So under emotion regulation, two of the things that they point out is, one is the story of emotions. So we need to be able to break it down. What was the prompting event? What was your interpretation of the event? What body sensations did you feel? What body language did you see from the other person or from yourself? What was your urge? What do you actually do? And then can we give the emotion a name? And sometimes that includes having like a list of emotions on the wall or on a piece of paper that have different faces associated with them. I've seen recently an updated pain index that it was much more useful, I think, than the typical pain index. I think number 8 was like bees. Quite entertaining, but actually makes a lot more sense when you think about putting a pain index. But we have to give emotions some names. I mean, so many people have spent their entire life thinking that, happy or sad or angry, and also labeling those emotions as bad when there's no such thing as a bad emotion. There are maladaptive behaviors, there are unproductive emotions to stay too fixated on, but nothing's bad. Another thing that they focus on with emotion regulation is physical illness, or PLEASE, so the acronym is PLEASE. But it's pointing out that if you have a physical illness, in order to stay emotionally regulated, you need to address those. Our body has to be well for our mind to be well, for our emotions to be well. It's important to eat a balanced diet. It's important to avoid mood-altering substances other than any kind of prescription medication. So obviously, if there is some depression, anxiety, and you're on a mood-altering substance in the form of an SSRI, that's super important to focus on. But staying away from those other things, drugs, alcohol, too much caffeine, I would assume. Even some of the energy drinks have a wide variety of interesting stuff in them. But if those alter your mood, then those should be things that you should stay away from. Having a well-balanced sleep schedule, so not too much, not too little, and exercise, just do any. But that physical health component and having a well-balanced kind of middle ground kind of a lifestyle, because emotion regulation is very much tied into your lifestyle. And if you can get a lifestyle pattern, then it does help with that emotion regulation far more significantly. There's a couple acronyms that are used under interpersonal effectiveness that I think are pretty good. So Dear Man is one of them. These effectiveness skills are things that we want to teach to patients who have not been historically interpersonally effective, or who have in some situations and really have not in others. And that's one of the things you'll see with individuals with borderline personality and emotional regulation issues, is that sometimes they're great, and when they're on, and when they're not, then it can get a little rough. So describe one situation using specific factual statements about whatever the situation is. Express what emotions were experienced when the situation occurred and why it's a problem. How do I feel about it now? Assert oneself by asking clearly and specifically for what behavior change you seek. Reinforce one's position by offering a positive consequence if there is one, in order to get what we want. Remain mindful of the situation by focusing on what one wants and disregarding distractions through validation and empathy, and redirecting back to, so what is it that I want? Appear confident and assertive, even if one doesn't feel confident. I feel like that's an important thing for all of us to learn. If you walk into a room that you're not supposed to be, but you act like you are supposed to be there, nobody seems to notice. You just you blend in, and people act like you're supposed to be there too. And negotiate with a hesitant person to become more comfortable. Some other interpersonal effectiveness strategies that can be taught to patients are give. So use appropriate language, be courteous and non-judgmental. Interested, act interested to what's being said. So teaching them that if you want people to engage in positive social interactions, you need to maintain eye contact, ask questions, so that the other person you're talking to feels like you are interested in that conversation. Validate, so show understanding and sympathy for a person's situation. Validation can be shown through words, body language, facial expressions, but sometimes this stuff has to be taught to patients, particularly if they've not had a lot of skill in the past. And using an easy manner, so trying to encourage people to stay calm and remain comfortable during their conversations, to use humor, to smile. So just these really kind of basic social skills that when people haven't had a lot of practice, they do need that practice in a safe setting. Another acronym is FAST, so be fair to oneself and the other person. Use few apologies. Don't apologize more than once for what has been done ineffectively or for something that was ineffective. So I think that's important because many people are socialized in our society to just apologize and apologize and apologize. And then often the other person receiving the apology starts to get agitated and it doesn't really help. And you're really invalidating yourself by continuing to apologize. You're kind of setting yourself up to continually be wrong if you're apologizing too much. Apologize, it's done, it's over, let's move forward. Stick to one's own values, so staying true to what you believe in and standing by it. Not allowing others to encourage you to behave in a way that's against your own wills, and stay truthful. Honesty is probably the most important thing that I can think of in most scenarios, if not all, with the exception of if being honest is just mean and it's unnecessary, then I don't know, maybe that's not a time to be fully truthful. So when they looked at a study of this, Linehan, it was in 2015. So she actually looked at which components of DBT are the most effective. So there are a handful of them. So what she did is she compared the standard DBT package. So that was the weekly individual, weekly group, phone consultation, and the therapist, being able to connect in between. She compared that with DBT individual therapy. So it eliminated all the skills training and it removed all of the group skills training. So it was just an individual therapist working with the patient. They were also not allowed to do skills training in the individual therapy. So this was using like the cognitive behavioral techniques and maybe some emotion regulation discussion, but it wasn't exactly a traditional DBT therapy because there was no skill-based component. To control for the treatment dose, they did have an activity-based support group. So there's still a group, but it wasn't a DBT skills group. And that was delivered by case managers. And it was psychoeducation, some recreational activities, more of the artistic types of therapies. They also compared the DBT skills training. So with this, they removed that individual component and they just focused on the DBT skills. So they also made sure to control for treatment dose and ensure crisis planning. There was individual therapy, or the individual therapy was replaced by manualized case management, so there was somebody still checking in with them. And the case management did follow a strengths-based needs assessment model to help them find resources, manage crises, solving problems, but so none of that individual therapy component with DBT was associated with this. And then they compared all three groups. So during the treatment year, so they did this treatment for a year and then they followed back up with the individuals after the treatment year. So during the treatment year, what they found was the frequency of non-suicidal, self-injurious behaviors among those who engaged in the behavior, because not everyone did. But of those who did, there was more of them in the DBTI group than the standard DBT or the DBT skills group. Depression improved less in the DBTI group compared to standard DBT. Anxiety significantly improved in the DBT, the standard DBT package and the DBTS group, but not in the DBTI group. And there was no differences between groups in like emergency visits or hospital readmissions for any reason, including suicidality. So that was during the treatment year. Depression didn't improve as much, anxiety didn't improve as much, and there's more self-injurious behaviors in that DBTI group. And the year following that, there was no difference between any of the groups in the frequency of non-suicidal self-injurious acts, again, amongst those who engage in that behavior. Depression was more improved in the DBTI group than the other two. So essentially what you had is during the treatment year, depression didn't get better for those in the individual therapy without the skills training, but afterwards it's like they caught up and then went a little bit farther. There was also a significant difference in the rate of change in anxiety, with the DBTI group improving more than the other two groups also. So that skills training seems to be more effective in the right now while the skills training is going on, but that individual therapy may be more effective for the longer haul. Rates of suicide attempts, emergency visits, and hospitalizations were lower in the standard DBT, like the full package, than in either of the other two groups that didn't have the full package. So whether it was just the skills or just the individual therapy. So definitely in terms of like reducing all of those things, the bigger picture outcomes that the full package definitely provides a better outcome. So in summary, the interventions that include skills training were more effective in reducing self-injurious behaviors. They were also more effective in improving other mental health problems than the people who did not have the skills training. But the pattern of change for depression and anxiety with that individual therapy without the skills training group is kind of interesting. And it was similar for both disorders, or for both sets of symptoms, where they improved less initially, but then caught up that following year. And what the findings overall suggest is that the standard DBT package and the DBT package minus individual therapy, so just that skills group, shows advantages over just individual therapy during the acute year, and standard DBT might be particularly effective in maintaining those gains for that time period after. So should clinicians shift treatment from standard to either DBT skills or DBT individual? The data shows that DBT skills training alone is superior to nothing, including waiting list or standard group therapy, particularly for individuals for borderline personality disorder. So if you can't do individual and group, but you can do the skills training, if you have a patient with borderline personality or an emotion regulation issue, do that. The skills training component of DBT alone has also been shown to be effective across a wide range of clinical populations. So there is a lot of good research to show that you can apply this to far more populations than just those with personality or borderline personality disorder. And some limitations to the study, because the therapist couldn't teach DBT skills in the individual therapy condition. We don't really know if the DBT individual therapy alone with skills training would have been just as effective. There was also higher dropout rates for DBT I and S. So if you didn't have the full package, people for some reason were dropping out faster and more. So that's, it certainly confounds the data, but if you can do the full package, I think that's the take-home message.